So very good evening to all. First of all, let me thank the IMA Thrissur, APC, APT, Association of Pulmonologists Thrissur, for organizing this special CME on two important topics. And the first topic being tobacco is killing us and our planet, because as part of World No Tobacco Day. Thanks to Manjula sir, Thomas sir, and all senior members here. So my topic will be on life is short, make it last. So we know there are traditional tobacco stories. Many indigenous nations have traditional stories of how tobacco was introduced in their communities. And many stories emphasize the sacredness of the plant and its powers to both heal if used properly and to harm us if used improperly. And some says that the original tobacco was discovered about 18,000 years ago. And we know that tobacco was used by our medicine people for both healing and blessing. It was used as a smudge to ward off pests when the people went out to hunt and gather the original version of off. And because it contains nicotine, a natural pesticide. It was given as a gift when welcoming guests to the community as an offering to those requested to pray and share their wisdoms. So, but there are few differences between a traditional tobacco and a commercial tobacco. A traditional tobacco is smoked in a pipe for ceremonial purposes, and it is used as an offering, as I already told. And medicinal tobacco was again used as a painkiller. But commercial, what happens is a deliberate targeting of specific consumer groups and premeditated and conscious addition of chemicals that leads to addiction. And definitely when we compare, it scarcely contains any actual tobacco. So what this tobacco contains, if you see in detail, it contains 4,000 chemicals and 40 cancer-causing agents, 500 poisons. And what is this nicotine? It is poisonous. It is more addictive than cocaine and heroin. And it's so powerful that farmers use it to kill insects. It's having a legal addiction. And the use results in emotional dependence like mood leveler and user on control emotion response in everyday life, etc. The second part in a smoke is carbon monoxide and the compound in car exhaust that cause death. It causes again shortness of breath. It reduces the amount of oxygen the blood can carry. Tar, again the sticky residue that stains the fingers and teeth, and every smoker you can see that. It contains benzopyrene, one of the deadliest cancer-causing agent, and a lot of other chemicals which we can compare, like acetone, which is seen in fingernail polish remover, ammonia in floor toilet cleaners, cadmium in batteries, arsenic in rat poison, methane in cow manures, and formaldehyde in preservatives in dead bodies. So it is that such of chemicals and metals, aluminum, magnesium, zinc, silicon, titanium, silver, lead, copper, mercury, heavy metals. So finally, if you see nicotine is a hard habit to quit. On a milligram for milligram basis is 10 times more potent than heroin as an addictive substance. Smoking is an overlearned behavior, and a pack per day smoker estimates 6 dose puffs cigarette and 20 cigarettes per day. This is 43,800 doses per year. Only few behaviors occur more than that, like if you see the breathing as well as blinking. Now, why it is a hard habit to quit? Because anxiety is 87%, irritability is 80%, difficulty in concentrating, restlessness, craving, gastrointestinal problems, headache, and drowsiness. All sort of things can happen once you start quitting tobacco. And the health effects, I think many health effects. It is a small slide, so I think you cannot see that. So I will emphasize it. mainly you can see the cancers, all kind of cancers, which is a major chunk, especially the lung cancer, ischemic heart disease, chronic lung diseases, then stroke. These are the major. Now, a word about smokeless tobacco. So sometimes we think that, okay, somebody must have said that, okay, I stopped smoking, but I start chewing. But again, it is more danger. Chew, snuff, plug, leaf, and dip are all forms of smokeless tobaccos. And if you hold an average size dip in your mouth for 30 minutes, you get as much as nicotine as you would from 2 to 3 cigarettes. So in American Indian teenage girls have the highest prevalence rate in spit tobacco. And again, in India, the North Indian and Northeast. And 43% of Indian youth in Northwest use spit tobacco again. Again, it contains 28 cancer-causing agents. Again, you can see that the snuff dippers consume on an average 10 times more cancer-causing substances than cigarette smokers. It contains mainly the nitrosamines chemicals. Again, the local effects are also there, like tooth abrasion, gum disease, gum recession, heart disease and stroke, cancer in the mouth, pharynx, esophagus, and pancreas. Now, it increases the heart rate, it increases the blood pressure, bad breath, and reduce sense of smell. Of course, cancer is the #1 cause of cancer death among Indian women, lung cancer. And women death rates due to lung cancer have risen 600%. And about 90% of lung cancer deaths attributed to smoking. And chewing tobacco and snuff contain 28 different carcinogens. Smoking is a major cause of cancers of the oropharynx also. Again, increased risk of pancreas cancer, kidney cancers, larynx and esophageal cancers. So, okay, you can see some pictures there. Now, researchers shows that smokers infected with human papillomavirus have greater risk of developing invasive cervical cancer than non-smokers. And Indian women have cervical cancer at 3.5 times the national average. And tobacco is one of the behavioral factors considered to elevate the risk of cervical cancer. Diabetes is again a problem. Smoking and diabetes both reduce the amount of oxygen reaching your bodily tissues, resulting in poor circulation. And smoking raises your blood sugar level, making it harder to control. And of people with diabetes who need amputations, 95% are smokers. The nicotine is a vessel constrictor, reducing the body's blood flow, and smoking increases the cholesterol level and hardness arteries. And diabetes increase cholesterol levels and the level of some other fats in your blood. And the combined cardiovascular risk of smoking and diabetes is as high as 14 times than smoking or diabetes alone. So together, diabetes and tobacco use make it twice as likely that you will develop heart and blood vessel disease. And people with diabetes who smoke are 3 times more likely to die of cardiovascular disease than other people with diabetes. Now, a little bit on smoking and pregnancy. It's a big slide. Just I'll mention a few things there. Cigarette smoke contains more than 4,000 chemicals, as I already mentioned. Many of them are carcinogenic. And all these chemicals mix with mother's bloodstream and pass to the babies to cause complications like 20 to 30% of low birth weight babies, up to 14% of preterm deliveries, and about 10% of infant deaths. Maternal smoking has also been linked to asthma among infants and young children. And the most effective way to protect the fetus is to quit smoking. If a woman plans to conceive a child in the near future, quitting is essential. And quitting smoking within the first 3 or 4 months of pregnancy can lower the chance of premature baby or health problems related to smoking. Now, as I already mentioned these things, low birth weight, premature birth, stillbirth, respiratory complications, congenital heart defects, CNS, fetal, and infant death. The low birth weight, yes, it is because the nicotine and carbon monoxide pass through the mother's bloodstream. Nicotine constricts the blood vessels and reduces the oxygen supply. The red blood cells start to carry carbon monoxide instead of oxygen and reduce oxygen supply to the babies, and babies' growth and development affected, and it finally results in the low birth weight. Respiratory complications, again, because of the baby's growth and development is affected, undersized baby, underdeveloped body, and baby's lung may not be ready to work on their own, and delayed lung development, and finally increased risk of asthma and SIDS. Congenital heart defects. Smoking during pregnancy in the first trimester, elevated risk of congenital heart defects, especially right ventricular outflow tract obstructions and atrial septal defects are common. CNS defects, smoking during pregnancy, lifelong effect on baby's brain, and learning disorders, behavioral problems, relative low IQs. Mothers, smoking during pregnancy may cause health problems in mothers also, difficult getting pregnant, placental abruption, and placenta previa, premature rupture of membranes, ectopic pregnancy. So again, the science behind difficulty in getting pregnant, it is because reduction of women's fertility rates. Placental abruption because of early separation of placenta, bleeding and dangerous to mother and baby. And again, placenta previa, again, due to bleeding, cesarean section, placenta accreta, hysterectomy, etc. So all these things are known. Then PROM, premature rupture of membranes, are also there. Ectopics. And also, not always the particular pregnant women need to be smoked. Like she can have a second-hand smoke or a third-hand smoke. The mother and the growing baby are at high risk of developing lung cancer, heart disease, emphysema, allergies, asthma, and other health problems if the mother is regularly exposed to a second-hand smoke. Second-hand smoke is also called passive smoke or environmental tobacco smoke, and it is a combination of smoke from a burning cigarette and a smoke exhaled by a smoker, both. Now, second-hand smoke again contains, as I mentioned, that it contains tar, carbon monoxide, nicotine, and all others. And babies exposed to second-hand smoke may also develop reduced lung capacity, as I already mentioned, including SIDS and asthma. Now, what are the benefits of quitting smoking? Definitely, the baby will get more oxygen, even after just 1 day of not smoking. And there is less risk the baby will be born too early, and there is a better chance that the baby will come home from the hospital with the mother. And of course, there are a lot of advantages for the mother also. So I'm not going into details, already mentioned. A little bit on second-hand smoking. 4 out of 10 non-smokers, that is 40%, are exposed to second-hand smoke. More than 1 out of 2 kids, aged 3 to 11, are exposed to second-hand smoke. There are about 1.3 billion cigarette smokers worldwide, and this number is still increasing. And about 1 in 5 adults smokes, and tobacco use is the leading preventable cause of death. So, of course, you can see all those things in children. There is chances of brain tumors, middle ear disease, lymphomas, respiratory symptoms, impaired lung function, asthma, sudden infant death syndromes, leukemias, and lower respiratory illness. On the adult side, you can have stroke, nasal irritation, breast cancer, coronary artery disease, lung cancers, atherosclerosis, chronic obstructive pulmonary disease, asthma, impaired lung function, and reproductive effects in women, low birth weight, etc. So all sort of things can be there due to second-hand smoke as in a smoker. So already I mentioned most of these things. Non-smokers inhale mostly the side stream, SS smoke. We call it the SS smoke. The side stream smoke that comes off a cigarette between the puffs carries a higher risk than directly inhaled smoke. And second-hand smoke is a mixture of side stream smoke and the smoke exhaled from the lung of the smokers. It is involuntary inhaled, lingers in the air for hours after cigarettes have been extinguished. A second-hand smoke may cause a wide range of adverse effects already mentioned. And even there is a concept called third-hand smoking. For example, if somebody is smoking in a car, the particles of this cigarette smoke will clinch to the fabric of the car, and that will last even up to 12 hours in that car, and that is called a third-hand smoking. Now, cancer in second-hand smoke, estimated to cause around 38,000 deaths per year, of which 3,400 deaths are from lung cancer in non-smokers. And for adults, passive smoking seems to increase the risk of lung cancer. A side stream smoke has higher concentrations of cancer-causing agents. Now, pulmonary complications. Children who grow up in a home where one or both their parents smoke have twice the risk of getting asthma and asthmatic bronchitis. And children also have a high risk of developing allergies. Infants under 2 years of old and more prone to sits. And exposure to environmental smoke causes reduced lung growth in children. And again, it results in the reductions in the postnatal pulmonary functions. So secondhand smoke is dangerous in children. Heart disease also is a problem. The current US Surgeon General report concludes that short exposure to secondhand smoke, blood platelets to become stickier, damage to the lining of the blood vessels, decrease coronary flow velocity reserves, and reduce heart rate variability, and all these things causes an increased risk to heart attack. So better is, there is no such thing as no smoking session. No amount of secondhand smoke is safe. To conclude that part, environmental tobacco poisoning, either second or third hand, dramatically increases pulmonary morbidity. Smoking family members should be advised to quit smoking and do everything possible to minimize environmental smoke exposure to the children around them. Now, something about smoking cessation. Quitting smoking, the process of discontinuing tobacco smoking. Tobacco contains nicotine. As I already said, it's an addictive. Nicotine addiction has historically been one of the hardest addiction to break, and most severe forms of dependence where compulsive craving dominates the subject's daily life. Quitting reduces risk of smoking-related disease. If you see the epidemiology, I just mentioned 1.3 billion smokers in the world, 10 million deaths estimated by the year 2030. And smoking tobacco use is known to cause 90% of all lung cancers. Approximately 40% of smokers attempt to quit annually, yet less than 5% actually do so. And smoking cessation treatments have greater cost effectiveness and clinical efficacy. Now, again, not going into it, already mentioned all these health consequences of smoking. The compounds in tobacco smoke, as already again mentioned, the carbon monoxide, hydrogen cyanide, ammonia, benzene, formaldehyde, nicotine, nitrosamines, lead, cadmium. And once you quit smoking, these are the health benefits. Circulation improves, walking becomes easier, lung function increases up to 30%. Excess risk of CHD decreases to half that of a continuing smoker. Lung cancer death rate drops to half that of a continuing smoker. Risk of cancer of mouth, throat, esophagus, bladder, kidney, pancreas all decreases. Lung cilia regain normal function. Ability to clear lung mucus increases. Coughing, fatigue, shortness of breath decreases. Risk of stroke is reduced, and risk of CHD is similar to that of a people who have never smoked. Now, the problem with nicotine cessation or smoking cessation is nicotine dependence. Rapid delivery within seconds of nicotine in brain from smoked cigarette contributes to its high abuse potential. Nicotine stimulates the release of neurotransmitter dopamine in the midbrain. And dopamine induces feelings of euphoria and pleasure and is responsible for activating the dopamine reward pathway, the mesolimbic pathway. Now, stimulation of the reward pathway reinforces the behavior so that it repeats. The other thing which plays a crucial role in reinforcement effects of nicotine are upregulation of alpha-1 beta-2, NACHR in cerebellum and brainstem, and reduced brain monoamine oxidase A and B activity. Now, pharmacological methods, the first line drugs which we use is nicotine replacement therapy, NRT, either in the form of nicotine gum, patch, lozenge, nasal spray, inhaler, sublingual tablets, vaporizers, etc. Antidepressants sometimes used, bupropion, and partial alpha-4 beta-2 nicotine receptor agonist, again, which is the last one came into picture, is varenicline. Now, sometimes we use antidepressant class like MAO inhibitors, and even tricyclic depressants are used. Then opioid antagonist sometimes used. Alpha-2 agonist is used like clonidine. Need of a newer drug is important because drug dependence, under 18 some drugs are not given. Development of tolerance, withdrawal effects, post-cessation weight gain and depression, and side effects of existing drugs. Because of these, the emerging medications are also important. We have a lot of emerging medications. The cytochrome P450, 2A6 inhibitors like methoxycyline, tancypromine, and then GABAergic agents like baclofen, tigabin, Then cannabinoid receptor antagonists like rimonabant and taranabant, lobilin, silver acetate, nicobervin. So all these are newer drugs which is coming into picture. Then we have the straws. The straws is an approach containing nicotine beads, allows the smoker to place drops of nicotine directly into a beverage. Now, galenic formulations of vernicillin also is coming. Control release of formulation, free base patch. Again, e-cigarettes, electronic nicotine delivery systems. Then alternative therapy like acupuncture, hypnotherapy, quit and win contest, and exercise interventions. All are coming. Behavioral therapies are tried. Immunotherapy, nicotine vaccines are also there. Like we have the cytochrome P450 inhibitors like methoxycillin, and I'm not going into details of that. So a little bit on vaccines, nicotine chemically linked to the carrier act as hapten. Antibodies nicotine complex too large to cross the blood-brain barrier. So it eliminates the brain rush that smokers experience, and there is no point in smoking for most addicted smokers. So these are some of the vaccines like CYT002 NICQB. It's a virus-like particle formed by the recombinant coat protein of the bacteriophage QB and slightly higher abstinence rate than controls. Then another one is NICVAX, nicotine recombinant Pseudomonas aeruginosa X protein A conjugate vaccine, a good abstinence rates. And then TACNIC is again immunotherapeutic vaccine yet to be studied further. Adjuvants, just a mention on glucose tablets. Hunger pains associated with the craving of cigarettes because of nicotine relieves hunger in smokers and useful adjuvant in smoking cessation. Then another one is tryptophan and high carbohydrate diet. Reduction negative effect, which is classic symptom of withdrawal. D3 receptor ligands, again dopamine receptor have a role in stimulus controlled drug seeking behavior. Then lobilin, normal medication evaluated previously, and mecamelamin. So again, these are again tried. This can be combined with the nicotine transdermal patch. Silver acetate, then atropine, scopolamine, and chlorpromazine combination act on muscarinic sites in cerebral cortex, which are involved in the mediation of nicotine withdrawal. So to conclude that part, newer forms of NRT like nicotine straw, pulmonary delivered nicotine, and nicotine containing electronic cigarettes have yet to establish their place in therapy in smoking cessation. Vaccines are new and a ray of hope. Behavioral therapies are important. Promising new therapeutic products are also coming up. All smokers trying to quit should be offered medication, and there is insufficient evidence of effectiveness for pregnant women, smokeless tobacco users, and light smokers and adolescents. And all 7 of the FDA-approved medications for treating tobacco use are recommended. There are no well-accepted guidelines for optimal selection. A higher dose preparation of nicotine gum, patch, and lozenges have been shown to be effective in highly dependent smokers. That is why we have gums of 2 mg and 4 mg, and consider prescribing second-line agents for patients unable to use the first line. Again, opioid antagonists are also sometimes used, not going into it. So finally, I think time after smoking, 20 minutes, the BP, heart rate, peripheral circulation all improves. 24 hours, the carbon monoxide level drops. 48 hours, nicotine eliminated and taste and smell improve. 2 to 12 weeks, the lung function can improve by 30%. And 3 to 9 months, shortness of breath and cough decrease. 1 year, the risk of MI reduced by 50%, and 10 years, the risk of lung cancer reduced by 50%. And 15 years, the risk of myocardial infarction and stroke reduced to the level of a non-smoker. So I think that is the one which we have to teach our smokers, or at least tell our smokers. So there are a lot of tobacco control programs to finally end the talk. All these things are the available smoking forms which we have. And again, prevalence of tobacco consumption not going into prevalence of tobacco. So Indian scenario in 2015, as already mentioned, 108 million Indian men smoked equally cigarettes and BDs, and 11 million women smoked between age 15 and 69. Our illiterate smoking prevalence rose, but fell modestly among men with a grade of 10 education or more, and that represents average of 1.7 million increase in male smokers every year. So again, from 1998 to 2015, the prevalence of smoking decreased in the age group 15 to 69, whereas it has rose in the age group of 15 to 29. So that is alarming. And Uttar Pradesh is the state with highest smoking prevalence of 18%. Then there are a lot of bodies like tobacco control legislation, the cigarette and other tobacco products, prohibition of advertise and regulation of trade and commerce came. That is passed by the Parliament in 2003 and notified by the Gazette in 2014. Prohibition of smoking in public places came into force in 2008, and labeling and packing rules came in 2009. Again, important provisions of the Act are prohibition of smoking in public place, prohibition of direct and indirect advertisements of tobacco products, prohibition of sales of cigarette and other tobacco products to a person below the age of 18, prohibition of sales of tobacco products near education institutes, mandatory depiction of statutory warnings, pictorial, all those things on tobacco packs, mandatory depiction of tar and nicotine contents along with maximum permissible limits. So all these things are the things which under the Act, and then the COPTA amendments in 2015, COPTA, that provision of COPTA amendments Bill 2015. So again, almost the same. Penalty came into picture, increases from 200 to 1,000, imprisonment of 2 years and up to 50,000 rupees fine for illegal production. Selling products with a warning will incur a fine of almost 10,000 rupees, a 1 year imprisonment. Again, approved products after pack hold only to 21 years, and ban on spitting also came into picture. An education institute, 100 meters. So all those things are known to us. Anyway, just mentioning. WHO tobacco free initiative in India. Again, setting up tobacco cessation clinics, 5 clinics in regional cancer centers. Then designated as tobacco cessation centers, TCC, which include training on cessation and creating awareness. Then resource centers of tobacco control, RCTC, development in 2009, helped in capacity building of other institutes to develop tobacco cessation facilities. National guidelines of treatment of tobacco depends in 2011. This is the National Tobacco Control Program, 2007-8. It now covers 21 states in our country, and the main objective is to facilitate the implementation of tobacco control laws to bring our great awareness about harmful effect of tobacco products under the framework of WHO. Components is again the same thing: public awareness, tobacco testing laboratories, mainstreaming components under NRHM, monitoring and surveillance, including surveillance. And state level, district level, there are various programs. State tobacco control cells are there, and all training sessions, all those things, school programs, etc. So I think that's a brief about those things. It's a big session. Thank you very much.
Thank you, Dr. Jodo Vajpayee, sir. It was a vast subject to be discussed today. Sir just highlighted very important points and it was very precise. Thank you, sir. It was an excellent talk. Now the session is open for the discussion.
So I think the questions we will take after the second talk. Is it okay, Dr. Jodo? We will be available. So both the question and answer session we will deal in the same time. Now let me invite Dr. Unni R. Baby, who is one of the best speaker of Association of Pulmonologists Thrissur. He doesn't need any introduction in a IMA crowd like this because he's a hardcore IMA office bearer. And he is an alumni of Pondicherry University, and he did his post-graduation from DY Patil Medical College, Mumbai. And he is very good friend of me. Not only that, when he was the past secretary of Association of Pulmonologists, and during his tenure, Association of IMA Thrissur won Best Club Award 3 times. So I would like to welcome Dr. Umi Arbeli for his excellent talk on what is new in asthma treatment.
Thank you, sir, for your kind words. Hope I'll be able to do justice to whatever you have said. So, good evening, everyone. In next 20 to 30 minutes, I'll be quickly going through the update on asthma care. I'll try my best to finish by 9 o'clock, as promised. So, just give me a moment before I just... technical team, 1 second. ഇത് കളയാൻ വഴിയുണ്ടോ ഈ മുകളിലത്തെ ഭാഗം മാറാൻ ഒരു സാധനം താഴേക്ക് ആക്കാൻ പറ്റും ഇതെല്ലാം Okay. All right. So, coming into introduction, asthma, as you are all aware, it is a chronic respiratory disease which is affecting up to 1 to 18% of the population in different countries. In India, it amounts to around 3.7 crore people, and 3.74 crore people are asthmatic. And India contributes to around 11% of global asthma burden and contributes to 42% of asthma related death. So India can be called as the hotbed of asthma or the leader in asthma. So how to come to a criteria of making a diagnosis of asthma? A history, we need, as you know, a history of variable respiratory symptoms and an evidence of variable airflow, expiratory airflow limitation. So these are the two things that we require to make a criteria for diagnosis of asthma. A history of variable respiratory symptoms include the symptoms are typical of wheeze, shortness of breath, and chest tightness and cough. People with asthma generally have more than one of these symptoms, and the symptoms occur variably over the time and vary in intensity. The symptoms often occur or more worse at exercises or while at night, and symptoms are often triggered by exercises, laughter, allergens, or cold air. Symptoms often occur or worsen with viral infections. And we have to see for an evidence of airflow limitations. This is shown by a spirometry or a peak expiratory flow meter, and evidence of decrease in an FEV1 layer, FEV1 value, that is forced expiratory vital capacity, forced expiratory volume in 1 second, and a documentation of FEV1 by FVC, which is a vital capacity, forced vital capacity ratio, which is below than the normal, then you can think as a diagnosis of asthma. And if you document that a variation in expiratory lung function, which varies up to 12% and 200 ml increase when compared to the previous value, then you go to a diagnosis, you can make a diagnosis of asthma. So when a patient comes with respiratory symptoms, we have to think if these symptoms are asthmatics, as I've said, cough, wheezing, chest tightness, shortness of breath, etc. If it is suggestive of asthma, you have to take a detailed history and examination for asthma. And if the history and examination supports your diagnosis, then go for a spirometry or a peak expiratory flow rate value checking. And if the results support an asthma diagnosis, then you have to treat for asthma. Suppose if your symptoms are not consistent with asthma, you have to go for further history and test for alternative diagnosis. And if your alternate diagnosis is confirmed, then you treat for the alternate diagnosis. And if you are not getting any alternate diagnosis, then you have to repeat or do another, repeat the test at another occasion or arrange for other tests, and you can confirm the diagnosis of asthma. And if still you are not getting a confirmed diagnosis of asthma, you have to consider a trial of for most likely diagnosis or and go for a further investigations. So suppose you are from the history you are getting a diagnosis of asthma, but the patient is not in a position to do an spirometry test because of his increased symptoms. Then you can start on an empiric treatment with an inhaled corticosteroids and on SOS basis of short-acting beta-2 agonist, and you can review the response and you can do the diagnostic test of a spirometry or a peak expiratory flow at 1 to 2 months after the symptoms. So coming to assessment of symptoms and to see the symptom control, what we have to ask, it is a retrospective analysis. You ask for the past week, what are his symptoms or her symptoms, whether they have had a daytime symptoms, which is more than twice per week, any night awakening, any use of the relievers like short-acting beta-2 agonists like an astanin or a salbutamol, any activity that limits their daily activities, any limitation in the daily activities. If none of these are there, then you can say it is a well-controlled asthma. If there are 1 to 2 of these are present, then you can say it is partially controlled. If they have 3 or more symptoms, then they are most likely, they are uncontrolled asthma. So what are the risk factors? You have to think when the patient comes with an uncontrolled asthma, you have to think of the symptoms and risk factors for exacerbations. You have to think of the medications, whether an inhaled corticosteroid is not given, poor adherence, incorrect inhaler technique, high use of short-acting beta-2 agonists like astatin, and comorbidities like obesity, chronic rhinosinusitis, GERD, confirmed food allergy, anxiety, depression, and pregnancy. And you have to think about the exposures like smoking, allergen exposure, if sensitized air pollution, etc. And you have to think of the settings as to environment that which the patient is living and the environment along with that. And you have to see for the lung function. If the patient is having a low lung function of FEV1 less than 60% predicted, then they are at higher risk. And you have to think of other tests to do also. And independent risk factor is ever being intubated or in intensive care for asthma care and having 1 or more severe exacerbation in the last 12 months. So having any of these risk factors increases the patient's risk of exacerbation even if they have few symptoms of asthma. So what are the other risk factors for poor asthma outcomes? The risk factors of developing a fixed airflow limitation include preterm birth, low birth weight, greater infant weight gain, lack of an inhaled corticosteroids treatment, exposure to tobacco smoke, noxious chemicals, occupational exposures, low FEV1, as I've already said, chronic mucus hypersecretion, and sputum or blood eosinophilia. And risk factors for medication side effects include when they are on systemic or frequent oral corticosteroids. Long-term, high-dose or potent inhaled corticosteroids can also can be considered as a risk factor. Also, if they are taking P450, 450 inhibitors, etc., and local when they are taking high dose of potent ICS or poor inhaler techniques. So these are all the risk factors. Suppose a patient is coming to you who has been already on a symptom, already on a bronchodilator, or somebody has already prescribed him an ICS LABA. In those patients, we have to see for their current status, whether they have a variable respiratory symptoms and a variable airflow limitations. If they have these symptoms, then you can confirm your diagnosis of asthma and directly go into the treatment. Suppose if you have a variable respiratory symptom, but no variable airflow limitation, the airflow limitation is fixed, then you have to consider repeating the spirometry and by withholding their bronchodilator. When it comes to short-acting beta-2 agonists, kindly withhold it for up to 4 hours before the test. And if you are using an inhaled corticosteroids, it should be stopped 24 hours prior to the test. And if you are using an ultra ICS LABA, that is ultra LABA, that is once daily dose of LABA, like liracatrol, then kindly withhold it for more than 36 hours. So, and once you repeat the test, and if you are able to show the reversibility and the reduction in an FEV1 FEC value, you can confirm your diagnosis of asthma. So that is how you should go along with your asthma treatment. If they have few respiratory symptoms, normal lung function and no variable airflow limitations, then we have to consider repeating the bronchodilatory responsiveness again by after withholding the bronchodilators as above, as I have already mentioned, and during the symptoms. It is considered, if it is still considered normal, you have to think of alternate diagnosis, and you can think of stepping down the controller medications that you will. If the symptoms emerge and the lung function falls, then you have to think of asthma and step up the controller treatment to previous effective dose. So persistent shortness of breath, again, we have to consider stepping up the controller treatment and up to 3 months, and then repeat the test as and when required. So diagnosis in countries like low and middle income countries like ours, it is asthma is often underdiagnosed. Differential diagnosis needs to be kept in mind, like tuberculosis, HIV, AIDS associated lung diseases, parasitic or fungal lung infections, and we need a syndromic approach and is often required. So JIRA recommends the confirmation of asthma diagnosis with lung function testing whenever possible before you start the treatment. Spirometry based test if it is available. If you do not have a spirometer at your clinic or at your setup, you can go for a simple peak expiratory flow rate meter, which is a very simple handheld device, and you can see for the responsiveness. You can ask the patient to blow and then give a bronchodilator and repeat the test after 15 minutes and see if there is an increase in their peak expiratory flow rate by 20%, then you can again confirm your diagnosis of asthma. So coming to what are the goals of asthma management. Once you confirm your diagnosis of asthma, you have to go for long-term goals of asthma management. The long-term goals are to achieve a good symptom control, to minimize future risk of asthma-related mortality, exacerbations, persistent airflow limitation, and reduce the side effects of treatment. And you have to think ask about the patient's own goal of achievement that they want to. So, what are the treatment options that is given by GINA? GINA recommends that treatment is given in 2 tracks. This was necessary to clarify. So, we have 2 tracks. Track 1, which is a preferred treatment as per the association, which is the use of low-dose ICS formoterol, inhaled corticosteroids, and LABA formoterol as a reliever is a preferred strategy. And it is preferred because the evidence shows that using ICS formoterol as a reliever reduces the risk of exacerbations compared to using a short-acting beta-2 agonist like an astalin reliever with similar symptom control and lung function. If it is not available or there are other issues, then you can go for a track 2, which is not a preferred alternative track, but that can also be used. While this is using considering regimen with SABA reliever. You can give your ICS with the LABA, any other things other than ICS formoterol if you are using, like your Seroflow or any other salmeterol, fluticasone, etc. You can use a SABA as your reliever or the astalin as your reliever. And then at severe patients, we have a new therapy. We have a new approach called a biological therapy, which I will be coming into in soon. So this is a stepwise chart that we use for diagnosing as well as for treatment of asthma. What you have to keep in mind is step 1 to 2, and we have step 1, 2, 3, 4, and 5. So initially, whenever the patient comes, we should always remember to have an assess, adjust and review your treatment. Always assess and confirm your diagnosis. If necessary, look for the symptom control and modifiable risk factors if anything is present. Look for comorbidities, inhaler techniques, adherence and patient preference and goals. So adjust the treatment modifiable risk factor, give treatment for that, and comorbidities. Look for non-pharmacological therapies that you can use for. Go for asthma medications, whether you need to step up, step down, etc. And look for symptoms in review. Always look for symptoms of exacerbation, side effects, lung function testing, and patient satisfaction also. So preferred treatment by GINA is a the track 1, which is using an ICS formoterol as a reliever, which reduces the risk of exacerbation when compared to an SABA reliever. So in step 1 and 2, we have to use an as and when needed low dose of inhaled corticosteroids and formoterol combination. In step 3, we use a low dose maintenance of inhaled corticosteroids formoterol, that is daily you have to give an ICS LABA combination. Step 4, we go for a medium dose, and step 5, we can add a leukotriene antagonist, LAMA, that is glycopyrimidine, tiotropium, etc. And refer for assessment of phenotypes of asthma, and also think about biologicals here. Alternative track, as I have already mentioned, is one using SABA. I'll not go into the details. And other options that can be used are to use a low dose ICS whenever you are using a Asthalin or a SABA. Go for a medium dose ICS, or add a leukotriene modifiers like your Montelukast, and add house dacimide sublingual immunotherapy when required. So that is, when you start the treatment, you have to first assess the symptoms and confirm the diagnosis, see for symptom controls and modifiable risk factors, go for comorbidities, see the inhaler technique, and see the patient progress and go. If the symptoms are less than 4 to 5 days a week, you can start them on step 1 or 2. If the symptoms are more are present in most days and they have breathlessness while walking, then they have symptoms of asthma more than once a week or more, then you have to go for step 3. If they have daily symptoms or while walking, and if they have recent subsequent exacerbations, then you have to think of step 4. And if they are still not controlled, you have to think of them as a severe asthma or difficult to treat asthma, and go for step 5. So what are the risk of mild asthma? See, I have already mentioned the step 1, step 2, we go for mild asthma. They are known as mild asthma. The mild asthma, what you have to keep in mind is the mild asthma with a patient are still at risk of serious adverse events. 30 to 37% of adults with acute asthma, and they have results with acute asthma, and 16% of patients had near fatal asthma. Even the mild patients have near fatal asthma, and 15 to 27% of patients, adults, are dying of asthma. So all these patients had symptoms less than weekly in the previous 3 months. So they all had a mild asthma, but even in mild asthma, the mortality rate is among 15 to 27%. So exacerbation triggers are unpredictable. Even viruses, pollens, pollution, poor adherence, all can cause exacerbations. Even a 4 to 5 lifetime use of oral corticosteroids, including Omnacort, Lodeflasacort, or whatever it is, causes an increase in risk of osteoporosis, diabetes, and cataract. So why the GINA is not recommending a short-acting beta-2 agonist alone? Regular use of Asthalin or SABA, even for 1 to 2 weeks, is associated with an increased airway hyperresponsiveness and a reduced bronchodilator effect, and an increased allergic response and increased eosinophil level. Inhaled SABA has been in use for more than 50 years, and asthma at that time, it was thought to be a disease of bronchoconstriction. The role of SABA was reinforced because it gave rapid relief to the patient. But what we have to keep in mind is that it can lead to a vicious cycle of encouraging of overdose. The patient always tend to use SABA whenever they feel an exacerbation or increase in their control, in their symptoms. So overall use of SABA is associated with an increase in exacerbations and an increase in mortality. And starting treatment with Asthalin or SABA or other short-acting beta-2 agonists alone trains the patient to regard it as their primary asthma care. So they just continue to using single reliever, and they will not be using their continuous regular medications. The only previous option that was available was a daily use of ICS, and then no symptoms, but then the adherence was an issue. The patient may not be ready to take your ICS LABA or a plain ICS on a daily basis. So the recommendation was changed once the evidence for safe and alternate approach was available. So now the treatment, we do not recommend SABA alone. It is recommended as needed low dose ICS formoterol in mild asthma, because when compared with as needed short-acting beta-2 agonists, the risk of severe exacerbations was reduced by 60 to 64%. Compared with maintenance low dose ICS, the risk of severe exacerbation was similar or lower. Small differences in other outcomes having favor maintenance to ICS was there, but what we can see is that all meta-analysis of all four randomized control trials, there was a 55% reduction in severe asthma exacerbations when using an ICS formitrol on a SOS and as needed basis than a SABA alone. Similar risk of exacerbation as with daily ICS and as needed SABA. So you do not have to give a daily dose for the mild asthma. You can ask them to take whenever they feel symptoms. And even the emergency department visits and hospitalization was reduced by around 65%, when compared to patients from SABA alone, and 37% lower when compared to patients who are on daily ICS. So what are the other changes of medication that has been recommended in 2022? Long-acting muscarinic agents or LAMA, that is tiotropium, should not be used as a monotherapy for asthma, that is not without ICS. It can be used as an added therapy, and adding LAMA to ICS LABA can have a small increase in lung function, no clinically important benefits for symptoms or quality of life, and modest overall reduction in exacerbations were seen. So coming to difficult to treat asthma and severe asthma, what is difficult to treat asthma? Difficult to treat asthma is an asthma that is uncontrolled despite prescribing of medium or high dose of ICS LABA treatment, or those patients that require high dose of ICS LABA treatment to maintain a good symptom control and to reduce their exacerbation. It never means that it is a difficult patient. And severe asthma are the ones that is uncontrolled despite adherence with optimized high doses of ICS LABA therapy and the treatment of contributory factors, or that worsens when high dose is reduced. So anybody who requires high dose regularly is considered to be a severe asthma. Approximately 3 to 10% of people with asthma have severe asthma. Severe asthma places a large physical, mental, emotional, social and economic burden on patients. It is often associated with multi-morbidity. So how to treat a patient with, investigate and manage a patient with asthma, patients with difficult to treat? First, we have to confirm the diagnosis, whether it is an asthma, you have to go for other diagnosis. Look for the factors contributing to the symptoms, like incorrect inhaler technique, suboptimal adherence, comorbidities including obesity, gastroesophageal reflux diseases, chronic rhinosinusitis, obstructive sleep apnea, etc. You have to look for modifiable risk factors as in home or at work, and which includes even smoking, environmental exposure, allergen exposure, medications such as beta blockers, NSAIDs, etc. Overuse of SABA relievers, medication side effects, or anxiety, depression, and social difficulties. Then we have to optimize the management, including asthma education. You have to educate the patient, optimize the treatment, consider non-pharmacological interventions like smoking cessation, weight loss, OSA treatment, etc. Treat for comorbidities and modifiable risk factors, and consider non-biological add-on therapies like LABA, LAMA, etc. Consider a trial of high-dose ICS in those patients. If the asthma is controlled, then you can consider stepping down of the therapy. And if the asthma becomes uncontrolled, if the treatment is stepped down, then you have to think of a severe asthma. If the asthma is continues to be under control, then you have to continue optimizing the management. So once if the asthma is uncontrolled, then you can diagnose them as a case of severe asthma, and you can send them to specialist asthma care and asthma clinics. So what are the other investigations that we look into once the patient is diagnosed as a severe asthma? We go for investigations for comorbidities, differential diagnosis, and we look for other cases like we go for investigations like CBC, CRP, IgG, IgE, IgM, IgA, etc. We look for fungal precipitants, look for bone scan, chest X-ray. We look for adrenal insufficiency in these patients, look for blood eosinophils, hypereosinophilia, and other social, psychological, physiological issues. So then what we have to keep in mind is whether they are a type 2 airway inflammation. Type 2 airway inflammation is one where the patients have a high blood eosinophil level, where their fraction of expired nitric oxide is more than 20 ppb, sputum eosinophils level is more than 2%, and asthma is an allergic, clinically allergic juvenile, and for them they have to repeat the test and see. If it is a type 2 therapy, if you are not seeing any evidence of type 2 airway inflammation, then you have to again review your basic diagnosis, go for differential diagnosis, look for alternate diagnosis, avoid exposures, consider other investigations like sputum induction, HRCT, etc., bronchoscopy if required, and we can even try and add-on therapies also. Suppose if they are having a type 2 respiratory inflammation, then you can go for adherence test, consider increasing your inhaled corticosteroids use dose by 3 to 6 months, and consider adding non-biological treatment for specific type 2 phenotypes. And if the patient can be given an add-on biological therapy, then you can think of add-on biological therapies to be given. If the patient is not affordable, then or the availability issues are there, then you can consider stepping up to a higher ICS. If it is not already used, consider add-on therapies. And as a last resort, we can use oral corticosteroids or stop infective and stop the ineffective add-on therapies. So what are the anti-IgE therapies that we have? We have what are the biologicals that we have? We have the anti-IgE therapy, anti-IL-5 and anti-IL-5R therapy, and anti-IL-4R therapy and anti-TSLP therapies. So these are the therapies that we can give these patients, and we can choose the ones which is eligible. Eligibility is dependent on the factors that predict the good outcome. Like if the patient has a high blood eosinophil levels, fever is more than 20, allergen-driven symptoms, childhood onset of asthma, you go for omalizumab. If the patient has a high blood eosinophils level, more exacerbations than the previous year, adult onset of asthma, nasal polyps, etc., you go for benralizumab, mepolizumab, etc., which is anti-IL-5 therapy. And if the patient has a higher blood eosinophil and a higher FeNO level, you go for anti-IL-4. And if the patient has higher FeNO, higher blood eosinophils with other parameters being down, you can go for an anti-TSLP therapy. So we have to extend the trial for 6 to 8 months if the patient is showing an evidence. If they are not helping, then you have to step down the therapy, consider switching to other different types of therapy, going for bronchial thermoplasty, etc. If they are having a good response, then you continue with your treatment, you review the response, and reevaluate the patient every 3 to 6 months, and review their lung function, etc. And you continue the optimizing the therapy, inhaler technique, adherence, etc. So, as I've already said, these are the various anti-IgE and biologicals that is available. Issue with the biologicals is a cost. Anti-IgE therapy, omalizumab, right now the cost is around 8,000 per vial, while mepolizumab will cost you around 1.80 lakhs per vial. So, if you are affordable for a severe patient, this is something that you can consider for. So, asthma exacerbations, just 2 words into asthma exacerbations. Asthma exacerbation is acute subacute worsening of symptoms and lung functions when compared with patient's usual status. We have to consider the management of asthma worsening as a continuum. Patient should have a self-written asthma plan. And patients who are at increased risk of asthma-related death, we have to think of these patients. Any history of near-fatal asthma requiring intubation and ventilation, hospitalization or emergency care visit for asthma in last 12 months, not currently using ICS or poor adherence with inhaled corticosteroids, currently using or recently stopped using oral corticosteroids, overuse of relievers, that is if they are using more than 1 canister per month, lack of a written asthma plan, history of psychiatric disease, confirmed food allergy, and these are the patients that we have to seriously look into. What are this is written asthma plan is something that Gina is very much recommending this year. All patients should have a written asthma plan, And the aim is to show the patient how to organize and respond to worsening of asthma. It should be individualized for patients' medications, level of asthma control, and health literacy. It should be based on symptoms and or peak respiratory flow. The action plan should include the patient's usual asthma medications, when and how to increase reliever and controller or start the oral corticosteroids, how to access the medical care if symptoms fails to respond, and why it is required. When corroborated with self-monitoring and regular medical review, action plans are highly effective in reducing asthma mortality and morbidity. So written asthma plan should be there for all the patients from early or mild patient up to later severe. So what are the medication options that we give for? We can ask them to increase the inhaled reliever, increase the frequency as needed, adding spacer for if you are using a metered-dose inhaler, early and rapid increase in inhaled controller up to, and inhaled corticosteroids. So we can give up to 2000 microgram can be given per day, or budesonide is the one that has been mentioned here. And option depends on usual controller medications and type of LABA that you are using. And coming to management of exacerbations in a primary care, what we have to see is, assess the patient, if it is asthma, risk of any asthma-related death is out there or not, and see for severity of exacerbations. So severe exacerbations, life-threatening ones are the ones who are drowsy, who are not able to, or silent, or the ones who have silent chest, you have to directly refer to higher center. Severe ones are the ones who are talking in words, and they sit hunched, and hunched forwards and are not able to speak. So these patients are agitated, and all these patients are again to be referred to a higher center. If mild or moderate are the ones who are able to talk in sentences, prefer sitting or to lie, and not adapted to the agitated, and they are pretty comfortable. You can give them short-acting beta-2 agonist if you do not have mobilizer at your clinic. Even a simple Asthalin MDI, even 4 to 8 puffs is enough to relieve the symptoms. You can continue, repeat it for every 20 minutes up to 1 hour, up to 1 hour to see whether they are improving or not. If they are not improving, they need to be referred to a higher center. So what are the follow-up that you require? Follow-up of all patients are regularly required after an exacerbation until symptoms and lung function return to normal. Patients are at increased risk during recovery from an exacerbation. This is also an opportunity. The exacerbation often represents a failure in your chronic asthma care, and they provide opportunity to review the patient's asthma management, and you have to see whether they, how well they are taking the medications, or what are the other issues, comorbidities, etc. And at each follow-up visit, you always have to check for patient's understanding and the cause of flare-up or exacerbation, modifiable risk factors like smoking, OSA, obesity, etc. Adherence with medications and understanding the purpose, why the patient is taking given a particular medications. We have to reassess, reassure, and tell them how to use. We always recheck the inhaler techniques at each visit when they come to your OPD, and always remember to have a written asthma plan. Thank you for your patient hearing. Thanks a lot.
Thank you, Dr. Ori, sir. I think sir has covered almost all the updates of GINA guidelines 2022. It was very crystal clear. And now I hand over to Dr. Thomas Varkan, sir.
I invite Dr. Jodo also to the stage. As we are running short of time, we will take a few queries from the audience. Mandira sir, any few queries from audience we will be taking.
I myself as an asthmatic since my childhood, and it has been badly affected when I got COVID, and I was taking medication from IMA.
I think so. You can start on as and when required ICS formatted. You can use your for record whenever.
Now I am settled, and I had cough for almost 6 months, and I lost, and my voice was also became worse, admitted twice, one in Deva Hospital, then Rajagiri. You know, so no, I had a course of clarithromycin which settled the problem. I took it for 14 days. After that, dramatically it settled. I don't know. But now I am on this thing. I mean, formoterol plus formoflow. Okay. Plus AB flow. That's all. But even if I miss it, I don't get. Things are going like that. Thank you. Anybody wants to say anything?
My question is to Dr. Judo. That was a nice talk. I wish I heard this when I was a medical student, when I used to smoke 10 to 15 cigarettes a day. Anyway, I think you highlighted every point, which is very informative, and that was a very good talk. My question is, you mentioned that worldwide, the number of smokers are increasing. Do you have any latest statistics to compare Kerala or India, whether it is increasing with all these new regulations and awareness to the people, especially for Kerala and India? Any latest statistics?
Test, I'm not sure. You have an idea? But generally in Kerala, the smoking is decreasing actually.
Yeah, that's what I have seen. Yeah. Even among the medical students, you hardly see anybody smoking, well, in the compound, at least now it is banned. Maybe they are smoking in the room or they have some other bad habits. Sorry? okay. Yeah.
Correct.
So, what is it? Oh, yeah.
What was the question? Can you repeat?
Is
decreasing or increasing?
Yeah. Statistics shows decreasing, especially in Kerala. And even in India, it is coming down, especially the smokeless tobacco is not coming down, but smoking is coming down. And actually the other additives are increasing on the other hand, especially in Kerala, we know the situation.
Stop, what is the role of nicotine tablet? Nicotine tablet. Feeling of nicotine tablet. Nicotine tablets.
Nicotine, okay. So nicotine, mainly we use nicotine chewing gums. Chewing gums, there are two strength coming actually, 2 mg and 4 mg chewing gums are coming. If it's a heavy smoker, like more than 20 cigarettes per day, we go for the 4 mg directly. As I was telling, a high dose nicotine gum is better than a low dose nicotine gum in heavy smokers. But moderate smokers or mild smokers, 2 mg gums are enough. Now the how to give it is we form a quick date. So I think we have to counsel the patient and the family members and all the friends, and then form a quick date. And the quick date, we stop smoke and start using nicotine gums. Now how to use nicotine gums? It's a chewing gum. You chew for maybe 2 minutes or 3 minutes, then park it under the gums, just like we use the gutka and all those things. And you can have a tingling sensation there. And you can go up to 15 minutes like that, and then finally you can spit it off. So that is why one Nico gum. Whenever you have a craving, that is one method, you use a Nico gum. Like if you are using 20 cigarettes and you stop smoking on one day, you start using the Nico gums. On the first day, you use 18 gums instead of 20 cigarettes. Because whenever you have a craving, you use a gum. Now what you do is slowly you reduce the number of gums, Nico gums. Like for example, after 1 month, you are using 15 gums per day. Now after 2 months, it has come to 10 gums. Now after 3 or 4 months, it comes to 4 or 5. And slowly you stop it. So that is the way we educate them. But one thing we have to very clearly tell them is, don't use a cigarette in between. Because if he start using a cigarette, then he will use both. Because this is also good, cigarette also is good. So you will start using the gums on one side, cigarette on the other side. And both addiction will be there. So always, and high level motivation is required, high level counseling is required. Always we have to call them back. Many times we have to sit with the family, sit with the friends. Especially friends is a problem, because when they have a party, immediately friend will smoke, he will have the tendency to smoke. So that is the way which we go. But again, the success rate is very, very less. It is less than 20%, the success rate.
In Northern India, I studied there, that's why. They use more tobacco chewing and they are not fond of alcohol. Because I studied my MBBS in Bihar in the 70s. So they don't want to drink alcohol, but they cannot spend a few moments without chewing a tobacco. Even our teachers are using it because they have got a special type of dubbing. I mean, both sides are open, middle it is closed. One side it is tobacco powder, and the other side is chunam. So there the tobacco is like that. If there it's on the street, it is openly sold. So this thing is there, 100 meters away you can get the smell. Because they are cultivating it there in Bihar. Here it is no smell is there, nothing is there. But it is not spreading to our South India also, tobacco chewing in the form of ants and whatnot. So that is an oral cancer, one of the major consequences of these things. I mean, can you elaborate it on that? Few things about oral cancer?
I think stop smoking is not an easy task. It's a real challenge. Many times patients will be asking, when I stop smoking, my cough is increased, my sputum production is increased. I would like to hear from Judo how he is dealing with this kind of queries.
Okay. So I think these are anticipated things because we know when we quit smoking, definitely smoking, nicotine, as I already mentioned in the first slide, it has a medicine effect. So in one way, it has some kind of anticholinergic effects. So that is why there's some dryness and the sputum comes down, and sometimes even the cough comes down sometimes. But that is only for the temporary. But slowly another cough starts, which is called a smoker's cough. So I think we have to educate them and say, you get rid of this, but you get a bigger price for you. So that's the only way we can explain that. And again, quitting smoking is, what I feel and what the experience we all have is, major problem is from the friends, not from the family. Family is ready to support. Cousins are ready to support, but friends are the problem. They will not allow them to quit. So I think first thing to counsel is the friends of this particular guy. I think then, but now slowly I think the number has decreased, but still I think a lot of young generation started smoking actually.
So I think tobacco, one thing is we always give more emphasis on smoking, and tobacco is wrong. I think that is one thing that we always. Smokeless tobacco is also easily available. So I think tobacco is the one that is issued.
You can get very small packets.
We will move on to the second talk. The important change in the asthma treatment came, I think, when we were doing our MBBS, MD time, and senior faculties, especially you may be knowing, we will use salbutamol as the first line agent in asthma. This has been changed in the recent guideline. They say, don't use salbutamol alone without steroids. This is just like drinking whiskey without water. So use salbutamol with inhaled corticosteroid. I want to get information from Dr. Undi regarding this.
I've already shown that in my slide. There are many large studies that has been done that shows that, as already mentioned, with the salbutamol issue is, we all see in our OP, they say they are taking an inhaler. When you see the inhaler, it will be a Stalin or a Duolin, and they take it at multiple times. So using one canister in a month is considered to be a high-risk patient. Using more than 3 canister in a year or more than 12 canister in a year, they are all candidates of high-risk asthma or uncontrolled asthma. And morbidity and mortality is there with asthma. Asthma is not just a mild airway hyperresponse, it just goes off with taking 2 drops of Asthalia. Asthalia gives you a rapid response. Initially it was considered as a bronchoconstriction, but we know asthma is not just bronchoconstriction, there is an inflammation part, and the inflammation part needs to be taken care of. To take care of inflammation, we need to give an corticosteroids, and the better, safer alternative is an inhaled corticosteroids for a longer use. So what we need to understand is initial mild symptoms. If you have 2 or 3 symptoms in a week, you need not take regular inhalers, so that is what they are telling. You can go as and when required ICS. You can use inhaled corticosteroids for plus your LABA, that is your Foracort Foracort is the one that they are recommended, that is budesonide, and ICS is the one that is recommended. You can use it as and when required. So that is one change, major change that has occurred in 2022 guidelines.
I think that is the take-home message. Never use short-acting beta agonists like salbutamol alone.
Excuse me, I have one doubt. That is, how long, if a patient is on Montelukast, how long or when can he stop the Montelukast, or how long should it take?
Montelukast is just an add-on therapy, as I've already said, it's like a reliever therapy you are using. You have to reassess and reassure them. You have to see in every 1 to 3 months and see with how much their symptoms are reducing. In your OP, you can use a simple peak flow meter, which is easily available, and ask them to blow forcefully and see what is the value. See in exacerbation and in symptoms. If they're having a better exacerbation, if their things are reduced, we can reduce all these oral medications. Recommendation guidelines are all going only for inhaled corticosteroids and LABA first. In India, we try to avoid it in every possible way, giving oral theophylline and other things. The recommendation is for asthma, it is inhaled corticosteroids plus a LABA. Before, the recommendation was an ICS when required, that is inhaled corticosteroids. Now it is an ICS plus LABA as and when required. So that is a major change, taking care both of bronchoconstriction as well as the inflammation part.
Okay. Another question is, how does exercise has any beneficial effect for the asthmatic patients? Exercise.
Swimming, walking, normal exercise, madam. Then the thing is, if they are going to do an exercise, they can take a SAV. If they are having a broncho, sometimes they have an asthma when it is induced by exercise, then they can go for a reliever before going for an exercise section, and then they can do their regular exercise. Any exercise is fine, and even weightlifting or anything. I think even the athletes, actors, everybody who has asthma, but they are continuing with their life. Asthma should not stop you from anything, so you can go that way, ma'am.
Okay, thank you. Any questions, Chad?
If no more questions,